Hello and welcome to the Bazooka. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at 10 OSCE stations in one clinical course. Today we're going to be looking at Season 2, Episode 5, and this is indeed going to be internal medicine. If you haven't yet subscribed, hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment. Thank you for helping the channel reach 1,000 subscribers. Let's see if we can get it to 2,000 subscribers before next year, June. So grab your piece of paper, grab your pen, and let's go. So we'll begin with our station 1. Study the image below and answer the following questions. Part A, describe the abnormalities in the X-ray. Part B, list the 3 causes. You may pause the video at any time. I will give you 2-second intervals. You already know the drill. I do not have to remind you, unless if of course you're a new person on the channel. And here comes the answer. So as we can see on this X-ray here, you have a total opacifications or a whole opacification of the left hemithorax. This is the left side of the X-ray. The left hemithorax over here. You have obliteration of the costal phrenic recess. The costal phrenic angles here, you can't really visualize them. You also have a silhouette sign of the right side of the heart. Over here, you can visualize it. You have deviation of the trachea to the affected side, also deviation of the trachea to the left side, rather, not the right side. This is supposed to be the left side. Even with the silhouette side of the left heart border. Then, of course, these are features that are going to be consistent with collapse of the lung. So here, the whole lung here has collapsed. So 3 causes: it could be due to pneumonia, it could be due to TB, it could be due to bronchogenic carcinoma. Moving on to the second station, study the image and answer the following questions. List 3 abnormalities. What is the most likely diagnosis? What is the underlying pathology? So take your time, look at the picture, and answer the questions. I will give you 2 seconds to pause the video. And here comes the answer. So, of course, as we can see here, you have the first thing being the loss of forehead wrinkles. So as you can see, it's no wrinkling. It's almost smooth on this picture. So loss of forehead wrinkles. You also have loss of ability to completely close the eye. As we can see on the left side, the left eye is not completely closed, whilst the right eye is completely closed. And then you also have this fold, which is known as the nasolabial fold. And there is a decrease in the nasolabial fold on the left side. Then you also have deviation of the lips, obviously. So this man here has a facial nerve palsy, and the underlying pathology here is a lower motor neuron lesion that's going to be affecting the 7th cranial nerve. Remember the rule of thumbs with motor neuron lesions affecting the 7th nerve: upper spares upper. So with upper motor lesions, you're going to be having intact features of the upper face. So it means that the person will be able to wrinkle their forehead, they'll be able to close their eyes completely. And if it's a lower motor neuron lesion, the lower spares the lower. So it means that they'll be able to have these nasolabial folds will still be prominent, and they won't be this decrease in this nasolabial folds. So it means that a lower motor lesion would present you with features of inability to close the eyes completely, loss of wrinkling of the forehead, and of course this is going to be pointing you towards a lower motor neuron lesions. Station 3, study the image and answer the questions that follow. Describe the findings shown on the image. What is the name given to this? Mention 4 associated diseases. So I will give you 2 seconds to think through this, and you may pause the video. And here comes the answer. So obviously these are hypopigmented patches, or you can refer to them as depigmented patches, and this is what we refer to as vitiligo. Then for associated condition, it's often associated with autoimmune conditions, so things like rheumatoid arthritis, autoimmune thyroid disease, type 1 diabetes mellitus, psoriasis, Addison's disease, systemic lupus erythematosus, celiac disease, as well as ulcerative colitis. Moving on to station 4, a 25-year-old girl presents with episodes of syncope. Take a history and ask important questions that will enable you to make a diagnosis. List the questions, don't write an essay. So pause the video, I will give you 2 seconds to think through this and actually give your answers. Shout at your screen if you may, or write it down on your piece of paper. If you get them right, pat yourself on the back because you are indeed getting ready for that exam that's coming up soon. And here comes the answer. So obviously you're going to be taking a normal history like you are already taking a history in the emergency setup. So remember that your history is going to start off with the demographics, which they have already given. So they've already given you obviously the name of the patient, the age of the patient, the gender will obviously be given, and it's quite obvious. But if this is a physical OSCE exam, please ensure that you first greet the patient, introduce yourself, and gain consent. And at the end of the OSCE exam, do not forget to complete your OSCE exam with thanking the patient. Even though you haven't finished asking all the questions you would have loved to, please thank the patient, as this it will attract some marks to your station. So you're going to be asking about the onset and the duration of fainting, as well as the frequency. How many times has it happened? The events that happened before. What was the person doing? What was the position of the patient at the time of syncope? Were they walking? Were they seated? Were they standing? What happened during the syncope attack? You should obviously get a collateral history if there was any presence of any abnormal body movements during the loss of consciousness or any possible injury, because this could be a seizure. Seizures could be confused for syncope. Then of course, what happened after the syncopal episode? Was there any memory loss? Was there any fatigue that was associated with this? Then you're going to be also asking for any presence of warning symptoms such as dizziness, nausea, and profuse sweating. You're going to be asking about precipitating factors such as exertion, swallowing, bowel movements. You also ask for other associated symptoms such as palpitations, tachycardia that may be linked with anemia, chest pains, shortness of breath that may be linked with some pulmonary as well as cardiovascular pathologies, even episodes of panic attacks in the past, and hyperventilation of the patient. And then the events that precede the syncope are also very important to find out. Was there any head turning or any tight necktie that was applied? Was this person micturating, or were they even shaving or even coughing before they fainted? And you should also ask about the history of syncope in the family, as well as a history of sudden death in the family. Some drugs can cause syncope attacks, so you should ask if this person is taking any drugs, specifically beta blockers, digoxin, antidepressants, as well as antiarrhythmic drugs. But you should ask for a past medical history of diabetes mellitus, hypertension, ischemic heart disease, as well as epilepsy. Do not also forget to ask about arrhythmias. Then also ask for a past surgical history of any pacemaker insertion or any cardiac surgeries that may have been performed on the patient. And also, last but not least, a history of smoking and alcohol intake. So this is just like you're taking a normal history, but rather in a much more focused manner to make a diagnosis or to arrive to a diagnosis of syncope and what exactly is causing the syncope. Moving on to station 5, study the slide and answer the following questions. Describe the abnormalities shown on the slide. What is the most likely diagnosis? What are the histological types of this condition? So take your time. I will give you 2 seconds to think through this, and you may pause the video. And here comes the answer. So as you can see here, we have this cell that appears like it's in a lacuna. So you refer to this as lacuna histiocytes. Lacuna just means like a lake. Then these cells are specifically referred to as Reed-Sternberg cells. So they are these giant cells that have this giant nuclei. You refer to as an owl's eye nucleus. So this is what is characteristically seen in Hodgkin's lymphoma. So this patient obviously has Hodgkin's lymphoma, and the types of histological types include lymphocyte rich, lymphocyte depleted, nodular sclerosis, as well as mixed cellularity. Moving on to station 6, a patient presented to the emergency department with cough and fever. Take a history and ask the important questions that will enable you to make a diagnosis. List the questions, don't write an essay. I will give you 2 seconds to think through this. You may start screaming at your screen right now. And if you haven't yet hit the subscribe button, please hit the subscribe button. Hit the like button as well. Drop a comment. It helps with the YouTube algorithm, and it helps push the channel further and further as we reach each and every medical student in the country, and eventually each and every medical student in the world. So here comes the answer. So this is just like taking a normal history, so your normal demographics. So if this is a physical OSCE station, please greet your patient. Please introduce yourself. Please gain consent. And then you can begin. At the end of your OSCE station, do not forget to thank the patient, regardless of whether you have finished asking your questions or you haven't. Then you ask about the demographics, so the age of the patient and the occupation, because this could be an occupational lung disease, the duration of the symptoms, the nature of the cough, if it's productive or non-productive. If it is indeed productive, what is the color of the sputum? Is there any blood present in the sputum? What is the amount that is produced? Is it copious amount or is it scanty? The presence of any symptoms that may be pointing towards TB, things like night sweats, weight loss, anorexia, as well as the presence of other symptoms such as chest pain, shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, easy fatigability, palpitations, as well as leg swellings. You should also ask for a history of pulmonary tuberculosis, a history of asthma, a history of chronic obstructive pulmonary disorders, hypertension, as well as HIV. Ask for a drug history because they could be reacting to certain drugs and certain medications, a family history of asthma, as well as a family history of TB. You should also ask for a TB contact, especially in the past 2 years. Then, of course, a history of smoking and alcohol intake. With smoking, it should be the type of cigarettes they smoke or the type of drugs that they smoke and the frequency. Moving on to station 7, a patient presents with a swollen abdomen and parotid enlargement. I think the last part of this question was take a relevant history. Apologies for not including it on the slide. So again, I will give you 2 seconds to think through this, and here comes the answer. So obviously you're going to be asking about the duration of the abdominal swelling. You ask if there's any history of swelling of the feet or the face that may point towards other causes, such as, for example, heart failure, even chronic kidney disease. You ask for history of yellowing of the skin and yellowing of the eyes and the palms, which may point towards a chronic liver disease. You ask about any fever, any anorexia, weight loss, and even gynecomastia, which is enlargement of the breast in males. And then you ask about any history of vomiting any blood or any history of passing dark stool, which is melena. And then you ask about any history of IV drug use, any tattoos that they got recently, any blood transfusions that they got recently, and if they have gone swimming in any streams or dams, or if there's any history of hematuria where you want to rule out schistosomiasis. You ask for a past medical history of HIV, or if at all they have been found with hepatitis. And then, of course, the history of alcohol intake, the duration, and the amount. Moving on to station 8, study the image and answer the following questions. Describe the findings. What physical signs would be elicited on the affected site? List 5 causes of the findings above. So I will give you 2 seconds to think through this, look at this x-ray, and shout your answers or write down your answers. If you are enjoying this video, drop a like, drop a comment, show some support. I do appreciate each and every comment and each and every person that puts in a lot of effort to support the channel, and thank you a million for helping us reach 1,000 subscribers. We still have a 1,000 subscriber special coming up on the channel where we shall be giving away some literature, of course, by your one and only Dr. Moses Kazevu. So please tell a friend to subscribe to the channel, because those will be announced very, very soon. So here comes the answer. So here, of course, you have a right-sided opacification of the lower lung. Over here, actually this is supposed to be a left, not really a right. I don't know how this is written right here. So everything on this answer here, I think let's change that. So this is supposed to be a left side. So this is supposed to be left side, because this is the left side of the chest x-ray. So you have a left sided opacification of the left lower lung. You also have a silhouette sign of the left hemidiaphragm. Okay, so this is supposed to be left hemidiaphragm, and you have left heart border as well, left heart border, and then you have deviation of the trachea to the right. It's supposed to be deviation of the trachea to the right, and of course this is a left-sided pleural effusion. Apologies for the confusion in the marking scheme and confusion in the answer. I think as my assistant, and yes, I do have an assistant, was making the PowerPoint, and then they made a mistake on the sides. And then on inspection, you have asymmetrical chest expansion. You have a trail sign on the it's supposed to be right side, a trail sign on the right side, meaning that the right border of the sternocleidomastoid muscle is going to stand out. You may have features of respiratory distress, things like use of accessory muscles, nasal flaring, intercostal as well as subcostal recessions. On palpations, you're going to have deviation of the trachea to the right. This is supposed to be to the right. You're also going to be having stony downers to percussion on the left. And then, of course, on auscultation, you're going to be having reduced air entry on the left side. So all these things are supposed to be changed to the left side. Apologies for the dreaded mistake that was made. Please don't make this mistake on your exams. If you do make this mistake, then you should have considered yourself to have gotten a 0 on this station. So 5 causes include pneumonias, TB, empyema thoracis, hemothorax, as well as a chylothorax. Moving on to the next station, the patient presented with chest pain, fever, and productive cough for 3 days, a duration with the following x-rays. What 3 chest signs may be elicited? What 4 cardinal tests may be helpful? What is the diagnosis? Take your time to look at this x-ray. You may pause the video if you do so wish. I will give you 2 seconds. And here comes the answer. So as we can see here, you have this opacification that you have here that's limited to the right side of the chest. And of course, we can see that it's present in the lung field, and it's also present even here on the lateral film. So this is obviously going to give you a negative aspiration because the pathology is not present in the pleural space. You're going to have downers to percussion. You're going to have increased vocal resonance. You're going to have bronchial breath sounds over here, and you're going to have reduced air entry because these are features that are going to be consistent with a pneumonia. Because if we're marrying the clinical picture of what is given and the x-ray, it's obviously going to be pointing towards a pneumonia. So the 4 cardinal investigations that I want to do, I'll do a sputum for microscopy, culture, and sensitivity, as well as acid-fast bacilli. I'll do a bronchoscopy, a bronchoalveolar lavage, as well as sputum for gene expert or PCR, as well as blood cultures. Then what is the diagnosis? So this is a right-sided middle lobar pneumonia. Then moving on to the last station, study the image below and answer the following questions. Describe the findings shown on the picture. What is the most likely diagnosis? What investigations would you order to make a definitive diagnosis, and what would you see? I will pause the video. And you may pause the video rather, and I will give you 2 seconds. I don't know what's happening to my words. I think I may be tired. So here comes the answer. So as we can see here, this left lower limb is edematous, and you have this dark papules on the left lower limb, and this is most likely Kaposi's sarcoma, to be specific, an African lymphadenopathic type, or a lymphadenopathic Kaposi's sarcoma. And you would of course order for a skin biopsy, where you are going to see 3 things. You're going to see prominent the spindle-shaped cells. You're going to be seeing prominent slit-like vascular spaces, and you're also going to be seeing extravasated red blood cells. And obviously that will point you towards Kaposi's sarcoma, which is often associated with HIV. Thank you for spending your time to listen to this Bazooka episode. Stay tuned for more of these episodes coming up as we prepare for exam week. If you haven't yet subscribed, please subscribe. Tell a friend to tell a friend that we are continuing the exam week on the channel. If you loved this video, drop a like, drop a comment, show some support. Share the link to this video, as well as share the link to the page to a friend that you think may benefit from these videos. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.